All
Great.
right, we're good to go.
Good afternoon, everyone. My name is Ahmed Abouesh. I am a psychiatrist. I've been here in Chico for about 20 years. It feels like a lifetime, but it was only yesterday that I came here. So I guess that tells you my age. Thank you very much to Butte-Glenn Medical Society for inviting me to present today on transcranial magnetic stimulation. Very exciting technology. Um, we finally have technology in psychiatry, so um, I'll be sharing what I know about it, and then we will have questions and answers and more of an open discussion. I also haven't presented grand rounds in quite a while, so do excuse me if I am a little bit rusty. So let's move the slides forward. There we go. Okay. An overview. Transcranial magnetic stimulation, or TMS, is a non-invasive tool that modulates the cortical excitability. We have known that when a substantial electrical current is induced in a stimulating coil, this produces a transient, time-variable magnetic field. And when this magnetic field is of sufficient strength and is applied to the brain, it can induce an electrical current in the brain, either increasing or reducing firing of groups of nerve cells. And that is really the basis of TMS and ECT as well. When this stimulation is applied repeatedly, it ends up changing the brain activity and as such treating different conditions based on the different protocols that are utilized. The science behind it goes back to the 1800s when Faraday demonstrated that changing magnetic fields can generate electrical currents. Basically, if you have a intermittent magnetic field and in that field you have excitable tissue, electrical currents are generated. Using this principle, Barker in 1985 in the United Kingdom used a single pulse magnetic device to stimulate the cortex and the spinal cord, using what was then a single pulse technology, which is still being used to this day. Basically, he had someone sit in a chair and stimulated one of the peripheral nerves, and the result was a contraction. Then it was more sophisticated by applying it to the motor cortex and observing muscle movement in certain areas that were localized. Current TMS devices are capable of generating a very rapid succession of magnetic pulses, and it's that we use to either increase or decrease the excitability of the brain cortex in different regions over a period of time, which leads to the use in cognitive, psychiatric, and different neurologic disorders. This is Dr. Barker here using his first machine. This was the newsprint after his discovery, and I met this guy. He's a really nice guy, and they purposely didn't register the technology or patent it. They left it as an open patent so that it could be used and developed by other people. These are different TMS machines and what they look like now. The Neuronetics machine was the first in the United States. There are different machines being developed and used in Europe, with most of them being quite similar in the fact that they have an H-shaped coil that creates the magnetic field. Except for this machine right here on the far left, lower left, which uses a different what we call an H coil. And you can imagine with different coils come different responses. And it's interesting what the indications that are being used for this machine. So this is the machine we have in our office, and it's an English machine. We have added this component here in front of the chair, which is a navigational tool to aid us in replicating the treatment sites and locations. The use of electricity or magnet devices or magnets to alter brain activity has been used for hundreds of years in different ways, from using fish that produce electricity or eels to different other technologies, but they were never quite strong enough to generate a strong enough magnetic field. The initial insight into the mechanism came from the observation that a single pulse from a coil applied to a certain area in the motor cortex, you all remember this picture, of course, resulted in a polarization and a muscle movement. So, and this is still a very integral part of what we do in localizing treatment site. We try to localize to the movement of the thumb. So we're basically moving a coil up and down, right and left, stimulating with a single pulse the different areas in the motor cortex until we're able to get either a visual or an EMG response on the muscles of the thumb, the abductor pollicis brevis specifically. The more accurate we're able to localize to the thumb, uh, the better the outcome as far as the treatment site. Through postmortem anatomical studies, they were able to localize the relationship between this area of the motor cortex and what we call the left dorsolateral prefrontal cortex, which we feel is responsible for or is the site of the centers controlling mood, specifically depression. Once we're able to localize that, then the coil is moved to the left dorsolateral prefrontal cortex and the treatment starts there. This is sort of a representation of the coil. This is a circular coil. We use a H-shaped coil, which creates a very specific and focused area that generates magnetic fields, basically in the middle of the H-shaped coil. With that, we are able to hone in onto the area in the brain that we want to treat, and there's multiple areas that treat different psychiatric conditions. And that creates depolarization or hyperpolarization of the affected area. The magnetic field is able to penetrate through the scalp and the skull to a depth of about 2 centimeters into the brain tissue. The H-shaped coil and the machine I referred to earlier, they refer to it as a deep brain stimulation. It is a little bit deeper. It's about 6 centimeters. And the importance is that we are not just stimulating the surface and the cortex, but it's the relationship between the cortical structures and the deeper limbic structures that actually creates this improvement in psychiatric conditions. I think I have something to show it later. Um, there's different physiological changes and parameters, excitability, the motor threshold, being able to stimulate the neurons. And so part of what we do is establishing what the threshold is to stimulate, and the alterations in the motor evoked potential, as well as cortical inhibition in different areas of the brain. One of the more important aspects of or changes that this does, or TMS does, is plasticity, and it's defined as the reorganization of the central nervous system through changes in the internal connections and the representational map patterns and or neuronal properties. Basically, plasticity is the ability of the brain to generate new connections and to fire in synchronicity. And it's believed that that is a huge aspect of how TMS is works or is effective. In depression, we know that it is a disorder associated with plasticity impairments, basically. And so the ability to regenerate these connections is very important. It is thought that the repetitive nature of the stimulation of these nerves, you remember, we're stimulating the same area. I'm sorry. We're repeatedly stimulating the same area of the brain. It's thought that this becomes the firing, synchronous firing, and the potentiation is increased and strengthened, which translates into a more meaningful and functional pattern of activity. I hope I'm not talking too fast. I tend to do that. So if I am, please tell me. One of the most impressive aspects of research in TMS was the conclusions we got from the neuroimaging effects of TMS on the brain. And that has really helped us understand how it works. Again, there's local effects, but there's still deeper effects. And what has been noted is before and after PET scans have shown increased blood flow and increased activity in those areas of the brain that were previously um, underperfusing, and as a direct effect of stimulation. I think I have a image coming. Yeah. So in the picture we have here, on the left is a depressed brain. Um, there's hypoperfusion um, of different areas in the brain. It denotes also that it's hypoexcitable, and that's again important in the techniques used to treat different psychiatric illnesses. This is a non-depressed brain. And so there's a stark difference there, um, in addition to loss of cortical matter and different things that happen. I did have a slide that had pre and post TMS specifically, but I think I deleted it while I was cleaning up, so do excuse me for that. So we believe that depression results in dysregulation of cortical activity with lower activity specifically in the left dorsolateral prefrontal cortex and higher activity in the right dorsolateral prefrontal cortex. So intuitively, you're either trying to stimulate the right side to excite that area, or you're trying to depress the right, I'm sorry, you're trying to excite the left side and excite the right side. And that application we have used in treating depression and anxiety. the hyperexcitable nature of anxiety, we use frequencies and protocols that reduce that or subside that excitability. On the other side, on the left side, that is hypoexcitable, we stimulate it in order to improve mood. So, one of the stronger evidence support this theory was that we noticed that the rate of depression in patients with left-sided strokes in the general population is higher if they have a left-sided stroke. Patients that had right-sided stroke experienced manic symptoms at much higher rates than the general population. This is a representation of how it works. Basically, this is the coil, an H-shaped coil that's placed over the target area. These yellow dots are the different regions affected by depression, and you can see the deeper structures. But because they are hyper-connected, or they're connected, what happens on the superficial aspect of the brain or superficial regions also affects the deeper structures. Some of the research, double-blinded study, high-frequency TMS increased and low-frequency TMS decreased regional cerebral blood flow in the frontal cortex. I'm sorry for the misspelling. The use of daily prefrontal TMS to treat depression stemmed from some of these findings, that there was hypermetabolism in the frontal areas in some depressed individuals. It's also important to note that it's not the idea of constant stimulation, but it's the intermittent stimulation that actually creates the improvement. So where is TMS indicated? Or how does it affect different psychiatric disorders? Major depression is the most widely studied disorder, with more and more other disorders being studied. Different meta-analysis of the research that has shown an unequivocal effect, or has shown the unequivocal effect of TMS on improvement of depressive symptoms. But there's also been research in anxiety disorders, among which are PTSD and obsessive compulsive disorder, using different protocols. So again, they are inhibitory protocols, as well as in schizophrenia. And I happen to treat one patient with auditory hallucinations. And the treatment center is different, the left temporoparietal cortex, and there was a reduction in the auditory hallucinations, which lasted to some extent. The current indications, FDA-approved indications, are a major depressive disorder, which is treatment resistance, and most of the devices are cleared for that. Obsessive compulsive disorder, and 2 of the 7 devices are cleared for OCD. Migraines, even though it does cause headaches sometimes, the benefit of migraines with auras was shown. Smoking cessation and the effect of TMS on addiction and cravings is a field that is really being developed at this point and looked at. Other indications that are not FDA approved but are being used are post-stroke, neuropathic pain, headaches, Parkinson's disease, and fibromyalgia. Compared to antidepressants, or where do you start using TMS? We know that through the STAR-D study, which was a landmark study, that the more antidepressant trials the patient has had, the more likely they are to fail those treatments. And it's a function, I believe, of the treatment resistant nature of the illness that the patient has had. What we have seen is the sooner you start treatment, the less likely resistance is to happen. And that's very important because we tend to use interventions in psychiatry quite late, when nothing else is working, right? But I believe very strongly that the sooner you start treatment, the more likely the success is, and the more likely the long-term outcome is. Compared to antidepressants, side effects are fairly simple. It doesn't have the systemic side effects that medication could have. This statement here about cognitive side effects is not correct because it occasionally has cognitive side effects. It is non-invasive, so compared to ECT, there's no need for sedation or anesthesia or recovery time. And it is effective where medications have started to fail. And basically, I've been doing ECT for 25 years or so. This has become a step in the protocol, if you will, for treatment-resistant depression, where it comes before ECT and after medication. In specific populations such as adolescents, it does show improvement in depressive symptoms in adolescents, but it's not as well studied, as well as in pregnancy, which is quite important as well. These are probably the absolute contraindications to having TMS, which is the patient has a non-removable conductive or paramagnetic or ferromagnetic sensitive metal implanted within 30 centimeters of the treatment coil, which could result in significant injury or death, such as cochlear implants, ocular implants, aneurysm clips or stents, bullet fragments, stents, either shunts as well. So very interesting facial tattoos with metallic ink. One doesn't really think about that, but that's another reason. Some of these are, such as the facial tattoos, are really a relative contraindication, if you will. Typically, a treatment course lasts between 20 to 40 minute sessions, 5 days a week, 4 to 6 weeks. There are newer protocols that have come out that are more accelerated. I remember when we first started, there was only a few places in the state that had TMS, and it wasn't covered by insurance. So in one of the meetings, someone was talking about how patients would actually fly in, it was San Diego, and make a vacation out of it. They would go in, since they were paying out of pocket, they would have 2 to 3 treatments or up to 5 treatments a day. And the treatment course was much shorter. Research out of Stanford has come out recently showing using a different protocol called the theta burst, which is about 3 minutes of treatment, and the patient having 10 treatments a day. Remember, there isn't that much side effects for 5 days, and the results were quite amazing, actually. We'll talk about durability, but maintenance treatment such as what we do in ECT has been looked at. The results are equivocal, so studies for and against it, But what we do is actually also keep the patient on their antidepressants, looking at the short durability of treatment and the long-term outcomes. Common adverse side effects include headaches and neck pain. The patients are subjected to a loud noise over a period of time, and so hearing loss has occurred. The risk of seizures is very low, but does happen. There are reports of different psychiatric symptoms developing because of different frequency TMS sessions. While no major cognitive effects have been reported, but some of these psychiatric symptoms and temporary cognitive impairment right after treatment have been reported. They usually resolve, not like ECT where things are sometimes protracted. This is very limited in duration and severity. So TMS versus ECT, really you're not comparing apples to apples, because with ECT and some of the studies that have been done, the TMS arm was fixed in number of treatments, for example, or the type of treatment, one-sided, while in ECT you are able to change the protocols. So I feel that it's really less than ECT as far as response, but the lack of side effects or the minimal side effects makes it a step before ECT is considered. Patient selection is, of course, very important. The stage of illness, how treatment resistant, the number of medication trials they've had, and the longevity of the disorder. Clinical response to other interventions such as medications or therapy, as well as augmentation strategies, are taken into consideration. The type of depression, whether unipolar or bipolar, whether it's elderly patients, which tend to respond less than younger patients. Adolescent depression, there is literature, but again, it hasn't been studied extensively as we've indicated before. And the other concomitant neurological disorders that might benefit from treatment. We've talked about some site pain, headaches as side effects, and we've talked about the seizure risk. We've only been using it for 8 to 9 years now, so again, the long-term effects on cognition so far have been very minimal. There is heat generation from the coil, and there's been concern about the effect of heat on the local contact area, but the heat tends to dissipate in the scalp fairly quickly. But one area is the safety of operators. Again, we don't know the longer term effects. So it's advisable to stay 70 centimeters or 2 feet from the coil and wear ear protection. Some of the earlier studies have basically shown that 33% of patients would get to remission of their symptoms, while 1 in 2 patients I'm sorry, 1 in 3 patients achieves remission, and 2 out of 3 patients show significant improvement in their response. Symptom relapse is really a big issue that is looked at, and the relapse rate really increases with the number of months that have passed. Because of the chronic nature of patients that I see, the patients I've noticed over the years have learned that this works for them when they do get depressed. And so they automatically come in and say, hey, I think I'm ready for it. I mean, it's worked for 6, 9 months, and I think I need another course. And it works again. So to minimize the risk of relapse, continuing antidepressant therapy throughout the treatment, continuing psychotherapy, the use of maintenance treatments, or a repeat course of the whole thing. To conclude, it is a focal and non-invasive form of brain stimulation. It's safe for most patients, fairly well tolerated. There's FDA indications for treatment-resistant depression and OCD. One of the devices is clear for smoking cessation and migraines with aura. I guess that's it. Questions?
Can I ask a question, Dr. Abouesh?
Yes, please.
How would you advise the parents of an adolescent patient differently than you would an adult patient with refractory depression as to whether they should get any kind of interventional psychiatry?
It really is based on the severity and the chronicity and maybe underlying medical issues. I remember I've treated maybe 1 or 2 adolescents with ECT over the years. And they came to me because one had a brain tumor and had surgery. And after the surgery, her mood really became quite depressed. And ECT was the only thing that worked for her. So it's really based on the circumstances surrounding the condition, severity, longevity, lack of response, treatment resistance, basically. So
Thank you.
you're welcome. Any other questions? Dr. Swerdling?
Yes, thank you. Very, very interesting talk. This similar technology is now being used to treat certain brain tumors in adults. So I'm really glad that you were able to fill some background information for me. My question is on the PET scan that you showed. It looked like there was a lot of subcortical activity as well. There were a number of yellow and green areas.
Yes.
Is that how important is that? Is that an indicator for success, or is it just sort of a paraphenomena that because you're looking at metabolic activity with the PET scan? Is it just those areas that are more sensitive to magnetic stimulation becoming more hypermetabolic, or can you use those as some type of indicator that the patient will have success or failure, or maybe it's not known?
So it does support the theories that it's the interconnectability of brain structures, cortical and limbic, plays a role in depression. So that was an important discovery to aid the theory or the hypothesis. It could be used as a marker as well, pre and post, and the benefits seen from comparing pre and post treatments. So I think it's one of the issues with psychiatric and neurological diseases. We are assuming some of the hypotheses, and nothing is really quite concrete. What we know is there is a very complicated interconnectability and connectivity and different roles for different neurotransmitters that not one theory stands by itself.
Thank you.
You're welcome. Any other questions? Okay. Thank you very much for putting up with me. Really appreciate it. Christy, you want to take over?
Yeah, thank you so much, everyone, for joining today. We're going to have another virtual grand rounds focused on more of the psychiatry work that's being done locally in another month, and we look forward to seeing you then. I also wanted to just mention that we are producing an academic forum on June 2nd from 3 to 6 p.m. This is through Healthy Rural California and our efforts to establish graduate medical education here in Chico. And it's going to be a great presentation and overview of what ACGME looks for in terms of sustainable and effective graduate medical education with Dr. Zwerdling, our DIO, and then we'll have Dr. Mitchell, who is the program director for our new psychiatry program, also give an overview of what that proposal will look like. We're preparing to submit it to ACGME in a couple of months. So look for the June 2nd academic forum for our community psychiatry residency. And thank you again for joining today.
Have a good evening, everyone.
Okay. Is that it? No, it's down here. So hit the bottom, the solid block, not the two. Yeah, that one. This one? Yep. And then, yes.